So my name is Valerie Cormier. I am a MD PhD working in Necker Enfant Malade Hospital in Paris, France. I am responsible for the French Reference Center for Skeletal Dysplasia, and I am also heading a team working on skeletal dysplasia, and a part of the team is specifically working on my syndrome. So today, I will try to illustrate how networks are important, network between researcher, clinician, and also, of course, between patients and clinician and researchers. So I've just introduced briefly the field of rare disorder. As you know, there are more than 8,000 rare diseases, with among them 70% which are inherited. In France, it affects around 3 million of individuals, more than 16 million in North America. 1/3 of pediatric emergency in the world involve genetic disease. There are about 50% of undiagnosed patients, and less than 10% are covered by treatment. It leads to major challenges, to urgent unmet medical needs for adequate and timely diagnosis and innovative treatment options. And it includes the need to name, meaning adequate and timely diagnosis, to understand, identify genes and mechanisms, to treat, finding innovative treatments, and to disseminate and advocate the knowledge in the field. So it leads also to virtual loops, which involve both clinicians and researchers in red and gray, beginning first with the importance of a clinical diagnosis, which will be possible through a consultation and which will lead to natural history, phenotype characterization, constitution of cohorts, and development of biomarkers, collect of patient samples, and we will go back to all these steps. Then it leads to genetic diagnosis following the identification of genes and new mutations, improving genetic testing. It leads then to preclinical research with the development of research tools and models, characterization of mechanisms, clinical research with the development of clinical trials, development of new diagnostic tools and new treatments, and finally coming back to the patients with treatment. There are different possibilities for the treatment, but also improving the diagnosis. So I will now move on my syndrome. This is exactly the story of my syndrome, beginning by patient making a clinical diagnosis, identifying the gene, allowing a routine molecular diagnosis, then developing functional studies, cellular and animal models, and hoping to develop therapeutic approaches coming back to the patients. Now, it illustrates also how concerted efforts are required between patients, clinicians, laboratory genetic and research team, and how a multidisciplinary approach is needed. So we begin first with the first two steps, patient and diagnosis. So it was the case more than 15 years ago. I had made the diagnosis of my syndrome. It was one of my first patients. The first diagnosis was a clinical diagnosis, of course, based on the clinical manifestation, meaning distinct facial features, deafness, some skeletal features. And with time, I collected the samples of 12 patients. So I followed 12 patients with my syndrome, and it begins quite important for me to try to identify the gene. So I collected DNA samples, and it was a long time ago. It was the beginning of exome next generation sequencing technology, and it was quite expensive at this period of time. So I selected 2 patients, 2 DNA, to perform exome sequencing analysis, and it lets me to identify in the 2 patients a mutation in the same gene, SMAD4. So I confirm that the mutation was also present in the remaining patients that I was following, 9 patients, but also through international collaborations, I had access to DNA samples from a total of 20 patients, and I was able to identify mutations in all patients, as it was always the same mutations, changing and arginine at position 500 in the 28 patients, but also a very closely located missense mutation in 2 patients. It was a de novo event in all cases. And based on this genetic analysis and based on the clinical diagnosis, we were able to say at this period of time that SMAD4 was really a good candidate gene for Myhre syndrome. So we published this finding, and as you can see, we found many mutation changing and arginine at position 500 located in MH2 domain. And this finding led to 2 different consequences. First, the availability of a molecular test to confirm a clinical diagnosis, and second, the possibility to perform functional studies. So we were with patients, we were with a clinical diagnosis, then we had a possibility of a molecular test, so the availability of a molecular test by screening SMAD4, and then we move on functional studies. And we go back to the patients. To perform functional studies, we needed skin fibroblasts. So we go back to the patients and collected skin fibroblasts. And based on the skin fibroblasts of Myhre syndrome patients, we were able to ask questions. What are the consequences of the mutation in SMAD4? And why it was important to ask this question? It was important because you have already heard that SMAD4 is known as a tumor suppressor gene. We know that loss of function mutations are responsible for juvenile polyposis syndrome, and it was quite difficult to understand how this gene can be also responsible for Myhre syndrome. We know that SMAD4 is quite important for TGF-beta and BMP signaling pathway. So the function of the gene was consistent with the possibility of its involvement in Myhre syndrome, but we had to find additional clues to further confirm that SMAD4 was a good gene. And there was one previous publication of a conditional knockout in a mouse model showing that SMAD4 was also associated, mutations can be also associated with short stature, hearing loss, and small cochlea in mouse. So it was another argument for SMAD4 as being a good candidate gene. Nevertheless, it was quite important to study patient fibroblasts to be sure that the functional consequences of those mutations could be consistent with Myhre syndrome phenotype. And indeed, thanks to patient fibroblasts, we were able to demonstrate that in patient fibroblasts, we observed increased SMAD4 level, leading to a gain of function mutation, which was really distinct from what is observed in juvenile polyposis syndrome. And we also observed an impairment of expression of TGF-beta driven target genes. And it was also quite important because overactivation of TGF-beta is now one of the major mechanisms supposed to be involved in Myhre syndrome. So based on those functional studies, we were quite confident that SMAD4 is a gene responsible for Myhre syndrome. So we had a clinical diagnosis. We had now the availability of a routine molecular diagnosis. We have some insight in the consequences of the mutation in SMAD4 with the finding of decreased expression of downstream TGF-beta target gene in patient fibroblasts. And we are now developing an animal model, a mouse model, and I have a separate tool dedicated to this mouse model. Why is it so important? It is so important because with a mouse model, we can have access to organ and tissue samples. We want to know why there is a heart, lung defect, for example. We want to understand what are the consequences on the long bone growth, on the ossification process, on cartilage, and having a mouse model which mimics the human phenotype is quite helpful, as you can perform histological analysis, but also more specific analysis studying RNA and proteins, which are quite important to further understand the consequences of the mutation. And the second interest of the animal model is also to be extremely useful for preclinical trials. You have a good idea of a new treatment in Myhre syndrome. You have first to test it in an animal model, and this is entitled preclinical trials. So I go back to the therapeutic approaches. So we have seen patient diagnosis, molecular diagnosis, functional studies, the importance of cellular and animal models. In the meantime, it is really important to go back to the patients and to prepare clinical trials. And to prepare clinical trials, we need to know the natural history of the disorder. What does it mean? What does mean natural history? Natural history is the usual course of development of a disease or a condition, especially in the absence of treatment. Why it is so important to understand the natural history? It is extremely important if we are facing clinical trials, because we need to know what we are going to follow, what are the complications, what are the main questions, and what is the clinical endpoints. What does mean clinical endpoints? Clinical endpoints are outcome measures referring to occurrence of disease, symptoms, sign, or laboratory abnormality constituting the target outcome in clinical research trial. It can be growth, it can be heart, it can be lung, it can be deafness, but we have to find something that will be easy to follow and that will be robust. And what we will call the primary endpoint. The primary endpoint of a clinical trial is the endpoint for which the trial is powered. And the secondary endpoints, these are additional endpoints for which the trial may not be powered, but maybe that the treatment will also answer those secondary endpoints. So if we think at clinical trial, the first step will be to describe the natural history and to find the primary endpoint. And of course, this is linked with the patients, because we will have to describe the natural history. So we will have to collect the data. We will like to collect database, and it needs to be done in close relationship with patient association and patient. So we have tried, so this is what is entitled translational research. This is clinical research directly linked with patient association, which allow natural history study, identification of endpoint, publication of guidelines and appropriate management, collect of patient database, epidemiology studies. This is quite important to know the prevalence of our rare disorders, and finally, going to clinical trials. So I will just briefly illustrate a study that we have performed a few years ago, trying to further describe the clinical spectrum. And this is one step quite important to understand the clinical spectrum and natural history. So it was performed in 2040. We collected the clinical data of 27 Myhre syndrome cases, including 40 females and 30 males, ranging in age from 8 to 48. All had the clinical criteria for Myhre syndrome, and all, of course, had the missense mutation identified in SMAD4. So they are all had the clinical and molecular diagnosis of Myhre syndrome. And we try to find specific features and additional features for all these patients. We observe intrauterine growth retardations in 22 of them, postnatal growth retardations in 20 of them, some degree of psychomotor delay in 20, behavioral troubles in 60, ear infections in 15, ocular anomalies in 12, abnormal puberty in 12, obesity in 12, velopharyngeal insufficiency in 9, and urinary tract and intestinal anomalies in 9. So it illustrates that some of these findings can be considered as endpoint, for example, short stature. We also observe, of course, hard malformations, including in 20, including patent ductus arteriosus, aortic coarctation, valvular aortic stenosis, ventricular septal defects, of course, hypertension, bronchopulmonary insufficiency in 10, laryngotracheal stenosis in 4, and pericarditis in 3. And we also go back to the skeletal features, trying to find some specific and some consistent features. And as previously described, we observe consistently short femoral neck, as you can see here, but also short hands, and also large short and large pedicles, large vertebrae with short and large pedicles. And we also observed thick calvaria. So all this work is quite important to find endpoints that we will be able to follow if we have some perspective in treatment. So I will finish my talk here, illustrating again how important are the concerted effort between patients, clinician, laboratory research, and research team. We are working on the animal model, but in the meantime, we need to work on the natural history of Myhre syndrome to find endpoints and biomarkers to be able to offer clinical trial and new perspective in the management of Myhre syndrome patients. And I will finish in showing my team and thanking all the patient association, mentioning maybe Caroline Michaud and Pauline Marzin, who are both clinical geneticists working on the natural history, Joanne Dubai and Alice Constantini, who are both researchers working on the mouse model, and Sophie Rondeau, who is doing the molecular screening and the, of SMAD4. And I thank you for your attention, and I will be happy to answer questions.
Thank you very much, and that's very, very exciting and interesting information. One announcement, you do have a separate recorded talk that will be available. That'll be available sometime tomorrow, I believe. So thank you for doing that as well. The first question that came in is, what do you feel are the current priorities for Myhre research?
I think it's heart, lung, and trachea. The more important questions, because they might be quite severe, they are impairing the quality of life, and they might be severe. This is my first point. My second point is behavioral troubles, and the third point is short stature.
Great, thank you. What can people that are interested in Myhre syndrome do to support advances in research?
So I think that there are different possibilities. Sharing clinical data is quite important, because we need to know precisely what is the natural history of Myhre syndrome. I am participated to some clinical trial in achondroplasia. You may, this is one, there are a few clinical trials, and the first step is always to describe natural history, and it takes time. So we need to be as precise as possible and to have all the specific features. So natural history is quite important, and it leads to database. And the second point is DNA and samples and fibroblast samples, but it's not always easy to obtain them.
That's great. And one plug for the foundation here, anybody that's listening, if you have not filled out your data for the registry, that's one way that we can also help. And us at the foundation are also doing a grant writing process, where if there are researchers that are further along or would like money for their own individual research, that is an opportunity for us to donate or to give them a grant directly. So keep that in mind as you do think about supporting the foundation. One other thought, so if you want to be a volunteer it seems like a lot of people want to think about volunteering for these natural history studies. Is there a way to do that?
I think that it is one of the most important points to describe a natural history. So it begins, we have a questionnaire. We have prepared a questionnaire. It's in French, but you will translate it easily in English. We have further discussed that with the foundation, with the scientific group. I think it will be quite important to be able to share this questionnaire and to describe the maximum of patients with Myhre syndrome. Yes.
Great. Thank you. One new question just came in. What do you mean by behavioral troubles?
So this is a difficult question, and there will be, I think, a talk dedicated to behavioral troubles and neurology. So some children have some behavioral troubles. So, and for the parents, it may be difficult to find the best way to treat them. So we need to be to combine psychological management, psychiatric management, and this is one important question for the families.
Great. So given these, the things you're doing with the mouse model, is there any idea on how many years to really get that data? Also for any trials and possible therapies, what kind of time frame are we looking there?
So the first step for the mouse model is to be sure that it really mimics the human phenotype. So we are currently deeply phenotyping the mouse model, and our first data shows that it mimics the human phenotype. We have been studying first the skeleton, and our mouse are short, and we are specifically studying the cartilage. And we, in the meantime, we are studying lung, heart, and trachea. So we need really to be sure that the histological aspect of the mouse model will be quite helpful to understand the human phenotype. And if yes, we will be able then to make some preclinical trial. But the deep phenotype will take at least 6 additional months, because we need to we would like to screen TGF-beta signaling pathway in all tissues, but also to perform additional studies for additional biomarkers. So I don't think that we will be able to begin preclinical trial. We will need at least 6 months or 1 year to be sure that we have the good model.
That's great.